Epicardial ultrasonography, presented by Dr. Gianmarco.
Well, thank you so much for the privilege to be here. I have no disclosures, and this is an experience based on the prevalence of coronary atherosclerosis in candidate to valvular surgery that ranges between 36 to 50, up to 50%. There is available on a clinical use an intraoperative high-resolution epicardial ultrasonography equipment that is validated in this method since the 80s. We report on 3 patients candidate to non-coronary surgery whose comorbidity or clinical status represented a contraindication to coronary angiography or an additional risk for postoperative complications. The intraoperative use of high-resolution epicardial ultrasound facilitated the detection of a critical LAD stenosis. We started in 2009 using this equipment that incorporates a module that measured the flow, so the function of the graft, along with an imaging module to verify morphology. And we use for all the anastomosis in our institution since 2009. Imaging are obtained according to a scanning protocol, either in a long axis or in cross-sectional view. The lateral scan performed across the anastomosis. The resolution of 2D imaging is able to visualize coronary intimal layer and the quality of the atherosclerotic plaque. The colorful imaging that is included in the equipment allows for a prompt view of a vessel lumen, giving a qualitative idea of the presence of possible stenosis. The case number 1 is an 83-year-old female with diagnosis of severe aortic stenosis, symptomatic for dyspnea according to the class 3 for the New York Heart Association. She was refused by cardiologists for contrast dye injection due to a recent episode of pulmonary edema and an acute kidney injury. This is a short axis view of an LAD, and we were able to detect a 70% critical stenosis. That was confirmed at a core mapping finding. Okay, the aortic valve was replaced and a saphenous vein graft to the LAD was constructed. Intraoperative graft verification by high-resolution epicardial ultrasonography and transit time flow measurement demonstrating a good functioning graft, a good prediction of the imaging method. This is the short axis view of the anastomosis with the protocol slipping the probe according to the short axis and with a core mapping scan. And this is the transit time flow measurement after the anastomosis completed. As you can see, there's a very high mean graft flow and a very good, very low pulsatility index with a pressure, with systemic pressure of more than 100 millimeter of mercury. The case number 2 was an 84-year-old female with a history of recent acute coronary syndrome and a left atrial myxoma protruding into the left ventricle. A moderate chronic renal failure was evident preoperative at preoperative workup. She was transferred to the operating theater after episodes of syncope. She did not receive coronary angiography due to the emergent surgery. This is the intraoperative finding by the 2D echo, and we detected 67%, so a critical stenosis onto the LAD. This is the feature with a cold flow imaging, and this is a long axis view that confirms the presence of a critical stenosis onto the LAD. The atrial myxoma was removed and a saphenous vein to LAD was constructed. High-resolution imaging and transit time flow measurement once again confirmed the patency of the anastomosis and a good prediction of the imaging preoperative scan. This is the postoperative 2D imaging of the cross-sectional anastomosis for a short axis of SVG to LAD anastomosis. And this is a the transit time flow measurement. It was taken during the total cardiopulmonary bypass, but it was the same just afterward when the patient with the chest, before the chest closing. The case 3 was a 67-year-old man referred for severe acute aortic regurgitation due to Staphylococcus gallolyticus infective endocarditis with a large vegetation on a non-coronary cusp. He was refused for coronary angiography due to high risk of embolism, and the preoperative CT scan was not taken because of a high heart rate. This is a long axis view, very clear, with a demonstration of critical proximal stenosis onto the LAD, 70%, so a critical one. This was the feature of a short axis. As you can see, was even a complicated plaque because there is an ulcer onto this. The color flow mapping demonstrating confirmed the prediction of the 2D imaging with the evidence of aliasing downward stenosis, a confirmation of a the critical value of it. A bioprosthesis was implanted and a Lima to LAD graft was constructed. High-resolution imaging and transit time flow measurement confirmed the patency of the anastomosis and good graft function. This is a feature actually not well clear, but it was working. This is a cross-section view of a 2D imaging with this method that demonstrated the full patency of the anastomosis. This is a color flow mapping from the same anastomosis. This is the transit time flow measurement taken by the end of the operation with a good mean graft flow and a good pulsatility index. We administered the dobutamine afterward in order to check the myocardial reservoir flow, and the flow, as you can see, increased by double, and the pulsatility index stays normal. A coronary CT scan was taken 15 days postoperatively, and it showed the perfect patency of a Lima to LAD graft, confirming intraoperative echoes and TTF findings. During the exam, radiologists localized LAD proximal stenosis, but he was not able to quantify it because of heavy calcification. And this is the result of postoperative CT scan. As you can see, there's visible stenosis, but not quantifiable. This is the control of a Lima to LAD anastomosis afterward, demonstrating a good patency of the vessel. All the patients are alive and asymptomatic. To now, in our experience, the method represents a feasible alternative to coronary angiography in properly selected situation, and it is the first report out of our knowledge of a coronary revascularization guided by intraoperative echo. Thank you very much.
I'm going to get you to have a seat, and we'll have questions after the next presenter.